Good afternoon for people in Montreal and good morning for people in California. Welcome to this last FMER Advanced webinar in the current academic year 2024. We are very pleased to welcome 3 scholars from Stanford. We are very proud and very happy with that. My name is Char Rodriguez. For all of you who don't know me, I'm a professor of family medicine at McGill University, associate member at the Institute of Health Science Education, and director of the Family Medicine Education Research Group. And I will stop here because the show today will be run by another researcher at the FMER, professor in the Department of Family Medicine and Canadian Chair in Advanced Digital Primary Healthcare, Professor Samira Rahimi. So go ahead, Samira.
Thank you very much, Sharo. Hi, everyone, and welcome. My name is Samira Rahimi. As Sharo mentioned, I'm Canada researcher in AI and Advanced Digital Primary Healthcare and faculty member here in the department and FMER member. I'll moderate today's session for you, and this session is hosted by FMER. So as you all know, AI is rapidly changing our practice in family medicine. That means that it's also changing how we teach and learn. So today we'll hear from fantastic speakers who are at forefront of this shift, exploring the AI means for medical education, both now and in the future, and what are the practical considerations for family medicine educators. So before we start, just a quick housekeeping notes. Please keep your microphones muted during the presentation. Feel free drop your question in Q&A box anytime, and we'll get to those questions and as many as we can at the end of the presentation. And this session is being recorded and will be made available after the webinar. So let's start. Welcome again, Dr. Sattler, Rydell, and Bajra. We are excited to hear from you, and floor is yours.
Thank you so much, and thank you so much for having us. We're really looking forward to talking with you today. We have a presentation and then look forward to questions and discussion after we finish. So thank you in advance for your questions and for your attention. I'm going to share my screen just to start the slides. All right, I think we should be set. Okay, oh, and then I just need to move our faces. All right, so the title of our talk today, so we're going to be speaking, we're going to be speaking about AI and in primary care, but specifically as it relates to innovations in medical education. We're grateful to be here and looking forward to talking with you today. We are 3 of us. So we have Dr. Rika Bajra here, who is our Associate Director of our Family and Community Medicine Clerkship within the School of Medicine at Stanford. And she also has recently joined our AI research team as the program director for our AI Academy that we're building. We're also grateful to have Dr. Tracy Rydell here. So Tracy is an assistant dean for clerkship education at the School of Medicine at Stanford, as well as the director of the Family and Community Medicine Clerkship. And I'm grateful to be here today. I'm one of the associate program directors for a research team at Stanford where we're called the Stanford Healthcare AI Applied Research Team. We are primarily clinicians and a research team studying the implementation of AI into healthcare environments. So we're not building technology, but we're partnering with people who are and helping to bridge that gap from development to implementation. So that's the lens with which we're coming to you today, and we'll go from there. So I just have one disclosure. So Omada Health, which is a digital health program, is sponsoring a research project that I've been a part of, but they were in no way involved with this presentation at all. So if you'd humor us and show us your virtual hands, wondering how many of you have used AI tools, even if it was just for fun. I see 2 people, so we have 18, 19 people on the call. All right, we're going up there. So 5 people putting up their hands of people who've used AI tools. How many of people are using these tools or any AI tools to facilitate your daily work or even just your life routines? So I know people use AI for different purposes. So a little bit fewer. I see 4 people with raised hands there, 3. And then the last question. So, what we're here today to talk about is the use of AI in medical education and also in clinical care. Is anybody using AI tools in that capacity? I see 2 hands, 3 hands, 4 hands. All right, good. Okay, so we have a handful of people who are using the tools. A lot of people here may be interested in learning more, and hopefully this can be a bridge and a way, our talk today can be a way to help you connect with some of the tools in a meaningful way. The objectives that we have today. So by the end of our talk and by the end of the session, we hope that you'll be able to describe at least a few. So our goal is 3 applications of AI in medical education, and be able to also compare and contrast some of the AI competencies, both from an expert perspective. So what do the expert think? What do experts think that we should be teaching? As well as what do learners want to learn, and what do the learners say that they need in order to be adept at this going forward in their careers. We hope that you'll be able to identify at least one tool that you can personally integrate. So how do we kind of walk the walk of AI utilizers so that we can be resources for our learners as we embark on medical education? And then also hope that you'll be able to speak to, at least a little bit or broadly, speak to some of the ethical concerns that we are observing and thinking about as it relates to integrating and using AI in the context of medical education. And also be able to, again, at a high level, potentially even speak to some of the ways that we might be able to address some of these. So I'm going to go over some core concepts, and then I'm going to hand it off to Drs. Rayadel and Bajra to speak to us a little bit more in depth about education, but wanting to make sure that we have a foundational level of vocabulary in which to have the discussion today. So history of AI. So I remember when I started talking about AI and there were just a few circles in this map, but now there are many. So one way to break it down, or one of the ways that we've been thinking about it, is there's sort of this nest of traditional AI tools. So that includes general artificial intelligence, so that broadest circle. So any technology that's able to kind of mimic human thinking and human thought processes in any way. And then a little bit narrower than that. So how do we use machine learning? So how do we actually train AI tools to be better? So how do we improve their ability to do the work for us or to mimic that human capacity by training them with data? And then deep learning, which is a level even deeper than that, which uses a variety of different tools to actually help not only train with data, but also to help the models make connections. So even furthering the depth of quote unquote intelligence that they can have. So those are what we categorize sort of in this traditional foundational AI that we've actually had around for a while. What's new and what we're all experimenting with, and what I think is has been really exciting over the course of the last couple of years, is this whole new world of generative AI. So how do we take AI from thinking to actually creating? And I think that obviously has unleashed and also with the way that it is available publicly, it's unleashed an entirely new generation and new realm of what we can do with these technologies. So when we think back to those core types of AI, there are 2 things that they're actually really good at. So AI, machine learning is really good at prediction. So we can look at a bunch of data and it can predict based on previous data what might happen in the future. So one example of that in the medical world is, all right, we can give you a bunch of claims data or electronic health record data, and it can pretty reliably predict which patients are more likely to land themselves in the hospital or re-land themselves in the hospital after they've been discharged, which has obvious implications for payer models and also clinical care for the patients. Traditional AI is also really good at grouping things into categories. So as opposed to saying this is what will happen, it takes a look at a lot of data and it says, all right, this data should be in this bucket and this data should be in that bucket. So for example, in the context of medicine, it can look at a variety of skin lesions and say, this one is likely to be benign and this one is likely to be cancerous or malignant. Traditional AI does a really good job of that when it's trained effectively. Generative AI kind of takes this to the next level, right? So this is where we get into, I think what many of us are just so excited about, because it can not only then take and look at data that we've fed it, but it can now actually create new content based on the learnings that it has, utilizing those traditional AI tools and that foundation. We can generate text, we meaning generative AI. So and there are many different models, but these models can actually generate text. So they can predict essentially what the next word is when you give it a prompt or ask it a question. That comes into play in our medical world, especially thinking of things like an AI scribe. So it can generate a clinical note from a transcript of a visit. AI can also generate images. So it can, based on a prompt or based on information, it can actually create you a new image. It can also generate audio or visual information, as well as actually just foundational code generation, which facilitates the creation of tools that we can use in all different contexts, including medical education. Some of the ways that we actually combine these types of tools. So, and again, keeping that comparison between what we can do with traditional AI versus what we're able to do or what we've been able to do with, or what we are able now to do with generative AI. So with computer vision technology, so we can utilize video, audio, transcript information to assess things like body language in clinical training videos, so simulated patient cases. But now with generative AI, we can not only assess what we're looking at, but we can actually generate things like images for training data sets, or we can generate voice or patient scenarios, things that can help enhance our ability to teach our students. With natural language processing, which is again a higher function task, we can utilize not only things like flagging or categorizing patients. So in this example, looking at clinical notes and identifying which patients should be high risk based on the content of the note. We can now actually use generative AI to create a clinical note, right? So it can actually take information and say, this is what it should look like, or this is what it should be, and this is how it should be organized, which traditionally I wasn't capable of. And then this idea of speech and audio, voice to text and text to voice, which are things that we're, again, I think a little bit more used to using. So with that, I'm going to hand it over to Dr. Rydell, who's going to talk with us about AI in medical education, specifically as it relates to educators.
Hello, everybody. And so I'm really excited to talk to you about this because I do think as an educator, the person who maybe struggles with the content the most ends up being able to educate others about it. And I think that it is a perfect example that I am being asked to speak about AI in medical education as an educator. I'm a family doc, and as I think all of us are here, and I think I'm kind of an old school educator as well. I like hearing patients' stories. I like their narratives. I like the interaction with the humans. And if I'm giving a lecture in front of a small group, for example, I like a good old-fashioned chalk talk where folks are, shouting things out and having some back and forth. And so then I hear this quote that I think came out of the Harvard Business Review, where it's, AI won't replace humans, but humans with AI will replace humans without AI. And oh my gosh, then I get panicked, right? Like, do I know enough? Am I keeping my nose above the surface of the water enough? And I hope that my perspective, that my imposter syndrome in this field will help, just bring the stress level down for all of us. We're all kind of begging, borrowing, and stealing from one another. And so this is just a really exciting time of information sharing. None of us are truly an expert. And so as the next slide will show, we can advance to the next slide. There's a bunch of different spheres in which we can employ AI as a tool, but recognizing that this is a constantly evolving field. And so we should just be really comfortable sharing our knowledge gaps with one another and really learning from one another. You can see the cool little swimmer icons next to a few of the planets that are around the orbit. Those are ones in which we'll take deep dives in the next few slides. And so I'll just briefly say a few words about the assessment and content summarization spheres from my perspective. I'm a clerkship director, and I also oversee the entire clerkship or rotation program at the School of Medicine. And when it comes to developing curricula or writing up evaluations for our learners, it can be absolutely overwhelming, right? These are tasks which either have strict deadlines and we want to do a good job being representative, or we are trying to come up with something novel and maybe we're worrying that we're missing a huge chunk of information. So for the example of assessment and evaluation, what we get as family medicine clerkship directors, for example, is we might have our students on a rotation and working with up to 8 to 10 different preceptors at the bedside over the course of 4 weeks or more. And each individual evaluator is writing something different. And how do we pull the themes then about that learner before us? And AI as a tool, if we tasked it with the evaluation completely, it comes up with something maybe that still sounds a little bit stilted. It doesn't really necessarily always represent the warmth that Dr. Bajra or I might be able to impart when it comes to representing this student's overall performance. But it can at least get us started, and we can use a prompt, something like, give us a summary of the different themes that you see from these different evaluators. And then we can weave maybe a warmer narrative that would be appropriate for a dean's letter. When it comes to the content generalization and summarization, it's like, oh my gosh, there's so many articles out there, or even on MedEd portal or something like that. There's so many different areas of content for a given curriculum. So if I want to give a talk on upper respiratory infections, where do I even get started? Well, I might be able to come up with a few learning objectives or things that I think are really important. And the AI tool can help us mine what's out there. It can help fill in any gaps. You could even write a prompt that says, what did I forget or what might be missing? And it can help fill in that knowledge. But I think sometimes we get paralysis by analysis when it comes to creating new content. It's like we're drinking from a fire hose and there's so much information out there, and AI can help us narrow down or at least organize our thought process so that we can come up with some either cohesive learning objectives, take those learning objectives and maybe expand those into slides or expand those into a talk. So, it's kind of all about writing a good prompt. But when we do that, then we can get that synthesis to be on our side. So I'm happy to do the next deep dive when it comes to personalized learning pathways. So I will admit that some of these institutions with whom we're sharing are United States focused. I am a huge admirer of the CanMeds framework. So I do want to give a shout out to our partners up north. It's, what is done with the physician competencies. I want to give a little shout out there, but we are going to call out a few of our peers across the states. And when it comes to personalized learning pathways, these tools are even being explored in K through 12 education, for example. Maybe a learner doesn't learn well from listening to a teacher at the front of the classroom or taking it to medical school or med school learning. I don't take notes well. I'm not an auditory learner. I like things more visually presented. These kinds of AI tools can help the learner that is in front of you, you really use their own assets to help take away the learning points more effectively. So for example, NYU has really done exemplary work here, where that individual is logging things like which patient they saw, which procedures they've done, which instructors have given them which feedback. And then based on the feedback that they've been provided, maybe the predictors that Dr. Sattler spoke about, like these prediction tools, it's like, oh, you may learn best if you explore cases in this format, or if you watch videos, or maybe you're somebody who likes to read a summary of various articles. So it can help you really understand how you learn best about various patient cases and can advance your knowledge. In the GME world, UCSF has a really interesting framework where, let's say that a particular resident is thinking about going into a different specialty field. As we know, many of our generalist practices have subspecialization then following residency. Well, what kind of elective might you want to explore, or what kind of cases might you want to learn from if you are thinking about going down a different pathway or are interested in learning about a particular case? So you take a general peds resident and maybe they're interested in learning more about a particular cardiology case. And that's where these personalized pathways can take hold. And then, I already referred to drinking from the fire hose, and in CME and continuing medical education, once we're out and about and practicing on our own, how do we even keep up? How can we continue to stay engaged with the ever-changing body of knowledge that's out there? New England Journal of Medicine knowledge, or NAGM knowledge, is based on helping us stay engaged by tracking what we learn from what guidelines are we interested, what kind of things are we continuously looking up in our own clinical practice. Programs like UpToDate and other algorithmic programs can also help us learn from things like that, and then it helps us look back as to what we're continually seeking to learn, and can help us stay on top of knowledge within our own specialty field. Happy to go to the next slide. So that was personalized learning pathways. And next, we're thinking about simulation. You can just, raise your hand to yourself if you use simulation at all as an educator. And I like to think about simulation in two kind of colloquial ways. It's, getting the reps in, and then operating in a safe space. And so a lot of what we know about simulation, I'm sure you've heard this before, a lot of it comes from aviation and being able to practice, how to fly the plane, land the plane, and everything in between without actually having passengers aboard. So we take those same principles in medical education, and simulation can be really effective in helping our learners practice something over and over and over again. Well, I think for many of us as educators, we can run one sim, right? Like we can maybe do a code practice or something like that. In family medicine, in our own clerkship, we have communication skills really highlighted, but that's once and done. And with AI at all different levels, whether it's med students at the UME level, residents at the GME level, or even practicing clinicians, this can help us, like I said, get the reps in and practice and even get feedback about our practice. So whether it's talking to a patient in a particular way, one example might be, in a gender affirming care case, like, are you using the patient-centered language appropriately and helping that simulated patient feel comfortable rather than excluded by the different words that we're using. For procedurally oriented residency programs, for example, AR, virtual reality, those types of practices can help with surgical techniques or maybe central line placement, et cetera. But even going back to the communication skills in the CME realm, for example, having difficult conversations, how could you practice with a virtual avatar or an AI tool? And maybe you fumble through the first few times when you're trying to deliver bad news or give a challenging diagnosis. And the more you say it out loud, the more polished you get. And that's great. Like you could just talk in the mirror, But with that AI tool, then getting some feedback like, actually, when you said that, I didn't feel that great. Like you would never get that feedback from the mirror. You might think that you're crushing it out there, and you may have actually used a term that could have alienated a particular patient. And so these simulated patient scenarios can be very helpful for even the most advanced practitioners if we are practicing a new skill. And then finally, for the area of admission and selection, this one is definitely a hot topic, but you can see here there's not necessarily, I guess I would say, like, we haven't necessarily cracked the nut perfectly because this is an area where we still need to tread very lightly in terms of avoiding biases. So we think about admission and selection, and it's like, gosh, you can imagine a family medicine residency program getting hundreds of applicants. And of course, every dean's letter says that their candidate walks on water, and every letter of recommendation says that this is the best candidate that you're ever going to see. How do you match what the core mission and principles of a given program are with the hundreds of applicants that walk on water? And so admissions AI usage aims to set objective criteria, and the AI tool can take away the, oh, but I really liked what they said in this one sentence. Like you can, I think that we still want to bring our heart and souls into admissions processes, but we want to make sure that we don't leave folks out. And so objectivity can help make sure that we are as inclusive as possible. I would say that we haven't fully solved the whole AI admissions and selection process because these tools are created by humans, and humans are inherently biased. And so any tool that we create, we need to consistently go back and revise and make sure that a diverse pool of content creators and AI generators are responsible for these predictors of success in our candidates, and so that we are really trying to stay true to a very vast and diverse set of criteria when it comes to admissions, because we would never want to shut the door on a really optimal candidate before they even get the chance to show their stuff. So hopefully that got your wheels turning in different roles or different hats that you may wear as educators. And I believe that Dr. Bajra will be speaking next about AI in medical education from the learner's standpoint.
Thank you, Dr. Rydell. So Dr. Rydell talked about a lot of exciting AI applications in the med-ed space. And what I like to do is just take one step backward and just take a look at what's out there in terms of what's published, what's out there in terms of the literature, and what are some gaps. So in the next slide, you'll see that this is a scoping review done last year looking at all the published literature in terms of AI content. I believe they went back to 1991. And the majority of the publications happened more recently, as you might imagine. I think most of it came after 2018. And happily, we initially started with pretty much perspectives, perspectives on what should be taught, whether it should be taught. And now we are much more into actual articles of innovations, things that authors have tried at their institution, things that they have evaluated. Most of these are done at the UME level. We're also seeing CME and GME at about 50% as well. In the next slide, you'll be able to dive down a little bit deeper in terms of what exactly is the content of these AI articles. Still, the vast majority is things like knowledge and attitudes. Is AI going to take over our jobs? Do you think it'll be helpful in your future? But an encouragingly high amount is on assessment in terms of how AI tools are used in clinical skills assessment, procedural skills assessment, just like Dr. Rydell had mentioned earlier. Things like multiple choice question assessment, essay test assessment. So this is a developing area and an area that has a lot of interest amongst medical educators. For teaching and instruction, there are now about 30 articles in terms of AI curriculum, what competencies we should be teaching, and the personalized learning tools that we covered earlier. The performance on the medical exams has been a really hot topic in social media, but I think we're kind of done with it. I think we kind of know that they do well on them, and we're probably not going to see a whole lot of that in the future. But 5, 6, and 7, I think there's some exciting developments. So clinical reasoning, how these AI tools are doing when we use them for virtual simulated patients, and using AI to assess learner notes in terms of clinical reasoning. Those are some exciting areas. As Dr. Riddell mentioned, the actual published articles on recruitment admissions is actually quite small. So it makes sense for us to take a cautious approach. And there's some administrative tasks that can be used, that can use AI down the line as well. So that's on a nutshell what we see out there currently. And in the next slide, I'll go over what medical students are interested in learning. So the vast majority of medical students, I just happened to pick this study, but I also looked at another study of Canadian medical schools, and very commonly students will say, yes, AI will be helpful for me in the future. I want to learn about AI. And the majority of them will say they're not aware of their medical school having options in terms of AI learning. Some topics they're really interested in include fundamental concepts in terms of, AI tool development and evaluation, but really when to use AI and the pros and cons of using AI. And what kind of struck me was that, students often seem to have some interest and some knowledge of the fundamental of AI. Like in some of these surveys, they say what they like to learn how to code. So that's far more advanced than many of us in terms of understanding the algorithms. But what they're really looking for mentorship is in terms of how to use it in the clinical context. So in the next slide, you'll see medical student perspectives from the qualitative portion of the study, in which they pulled representative quotes, and you can see that students in general do have a healthy skepticism about AI, as would be appropriate, and are really looking for leadership mentorship in terms of how can I use it responsibly and conscientiously. And I think as medical educators, we can think about this in terms of how do we use it, and how can we guide students in the clinical context of using AI tools. In the next slide, I have my last slide, which is proposed AI competencies. There are a couple of Delphi studies out there in terms of experts being polled in terms of various AI skills that would be recommended that we all acquire. I particularly like this one because I think it provides a nice framework for understanding AI competencies in a very practical manner. It's in the Annals and written by family physicians, which in my bias is the reason why it is practical and useful. But essentially, we're looking at what is this tool? How is this tool created? How does this fit into the bigger healthcare system? What other emerging AI tools are there? Should I use this tool? What is the evidence behind it? Putting on our evidence-based medicine hats in terms of thinking through what is the performance metrics, how is it performing in real life, and when should we be thinking about when it will not work, in terms of bias and fairness. Decision making, when should I use this tool, from the perspective of when is it most appropriate? This might be similar to how we use medical calculators, like the risk of patients having a pulmonary embolism or stroke. When we use these AI tools, like when is it context dependent in terms of when I should use this tool effectively and how to interpret the results. And then the technical use in terms of how do I use this tool? How do I be effective at prompt engineering and be efficient at using these tools? And what are the tools out there for curriculum development and assessment? How can I be more efficient in my work? The communication one is, to me, something that I think is underrepresented when competencies are discussed. And this is, how should I communicate about this tool to my patients? So if I'm using an AI transcription tool that will make a temporary recording of the encounter, what are the concerns about data privacy and security? How do I continue to build trust with my patients as I use these tools? And then the authors have awareness of unintended consequences as a cross-cutting competency. So it should really cut across all of the ones that we just talked about in terms of what are the side effects of this tool, thinking about implementation bias, equity gaps, any ethical and social challenges. And we'll go over that in the next portion of our talk. But I think, as we saw in the previous slide, these are the components that medical students are really, and learners are interested in understanding in terms of how do I use these tools ethically, responsibly, and conscientiously. So I'll hand it over back to Dr. Sattler.
Thank you, Rika. So for the final session, or final section of our talk, we wanted to just do a broad overview of, we've talked now, how do we use this as educators? What do our learners want? And getting to that part of how do we engage with these types of tools so that we can have the experience, so that we can better understand how to apply and why those competencies that Dr. Bajra just outlined, why are they important and what are some of the challenges with them, and why, and how do we experience and kind of immerse ourselves into these tools so that we can be better in the service of being better teachers. And so, for those of you who are clinicians, we think about all of the different tools that are available in the context of clinical care. So we have, right now at Stanford, we're using draft responses to patient messages. There's also tools that can offer message triaging, so messages that come in from patients and highlighting the ones that may be more urgent or require sooner attention. There are tools that are being developed to offer chart summarization. So instead of kind of combing through and doing chart review manually, what can the AI learn to bubble up for the attention of the clinician who's seeing a patient? How can we utilize AI to support clinical decision-making? So prompting us to consider alternative diagnoses or consider different types of treatment algorithms or treatment plans for our patients. Utilizing clinical applications also to help us address some of these issues of bias. So how can we easily generate patient instructions in different languages? That's a clear gap that we have in our current medical record systems. And then also to the use of ambient scribes, which we've talked about. When it comes to operational efficiency, this applies to a broader audience. So anybody who's doing anything related to medical or health system operations. So how do we utilize these tools to give us insight into things like capacity, revenue, the administrative tasks of scheduling and reminding patients to come in for visits? How do we generate, or is there an opportunity to generate insights from information that's generated by clinicians and patients in the way of messages and clinical notes? And then for, again, any clinicians out there, that dreaded task of prior authorization, it's an opportunity for AI to really improve our efficiency and help us navigate a very complicated medical system in a way that's more efficient and effective for our patients ultimately. And then in the realm of research, our team has been exploring some exciting use cases when it comes to, supplementing and as Dr. Rydell and Dr. Bajra both spoke to. So how do we use AI to augment what we're doing? So using it to augment literature review, which can be such an arduous task. So we still need to go to the literature, but how can AI help us fill in any gaps or blind spots that we might have in a review that we're conducting? One of our team members is doing a trial of utilizing generative AI as an accessory or an auxiliary coder for qualitative coding. For anybody who's done qualitative research, we know that finding coders can be a rate limiting step, and it takes an incredible amount of time to code different transcripts, but not replacing that task with AI, but augmenting it, having AI serve as an independent reviewer and help us with things like generating themes, back to as Dr. Rydell was talking about. How can we help it generate ideas for us to consider in addition to what we've generated de novo or with our team? Doing the manual tasks of data cleaning, data visualization, and then ultimately even supporting some of the more technical processes of generating or of writing. And how do we utilize it to help us make these parts of our jobs more efficient and effective? So some just highlights to get started. And again, some of these are a little bit US centric, but I think hopefully also relevant to you. I think in that top left corner, this is something that we on our research team live and breathe by, which is asking the question, not first, what AI should I use, but first actually asking, what is the problem? And is there a role for AI to solve this problem? We see a lot of people and teams who start with a fancy concept or an AI tool and try to make the system fit the tool. But we really advocate for this idea of a problem-solving approach to these tools because they're expensive, they're costly to not only purchase, but they cost a lot of time and culture shift to implement these tools across health systems. And in terms of change management, making sure that you're getting the bang for your buck, really want to make sure that it's solving a meaningful process or a meaningful problem for you. Helping ourselves kind of learn more. So there are a lot of different courses that you can take online. So the Society for Teachers in Family Medicine has a wonderful resource library, as well as things like Coursera, things that are more broadly applicable and available. Making sure that we're also doing the work to make sure that the tools that we're using have been validated and are deemed to be appropriate for use and also reliable. And picking things like frameworks that have data behind them or that have use cases that can be applicable broadly. And then, of course, if you're doing any clinical data, having to be keeping in mind front and center patient privacy and how that might relate to how you're using a tool as it relates to identified patient information. But I think right now we're just running with the goal of just trying to not include any identifying information in any searches that we're doing, even if it's in the context of a secure LLM. And then how do we, again, speaking of those high-risk tasks, how do we identify low-risk tasks that can just help us kind of whet our appetite for these types of tools, especially if you're not using them or you haven't used them? When we look at how we're applying tools at Stanford, we're starting with the low-risk use cases first so that we learn what is the rate of adoption, what are the ways that we can implement this in a safe and effective way for things that are low risk. So then we can build the learning, build the experience to then tackle some of the higher risk use cases. And then just going to end today with a couple key considerations, and then we'll switch to discussion. So, what are some of the challenges with AI, especially, as it relates to integration into our learning environments and clinical environments? So this is a big one. This one I think about a lot, actually. So there's this risk that we end up over-relying on the generative output. And then that ultimately ends up eroding our baseline knowledge and skill base. So for example, I'm in clinic and I have a draft response to a patient message. I have the clinical experience to understand whether or not that generated text is factual and real and appropriate for a clinical case. But somebody who doesn't have as much experience may not be able to make that distinction. So especially as these tools are new and being utilized and accessible to even our earliest learners, how do we keep an eye out for that development of an overall reliance on what's coming out or being generated by these models? Thankfully, we have a lot of experience in implementing education technology. And so one of the things that we can do as we move forward is to look at some of the lessons that we've learned as it's related to the adoption of education technology in other cases, and use some of that scaffolding to then apply to generative AI. We've come a long way as it comes to technology. I mean, I think about even from the basic level, I remember, can you bring your calculator in? Like, what's that going to do to our foundational math knowledge, right? If we're allowed to use a calculator. And we have succeeded in overcoming that barrier. That's a very rudimentary example. But I think it's illustrative of the fact that, we've had to build scaffolding around that type of use, and we will do the same with this. It's just that we're in the process of building it. The definition of what is appropriate use and what are the professional guidelines and boundaries around using these tools. I think about, what Dr. Rydell spoke about with using this for admission selection. or even generation of, letters or reviews of students. How do we use this technology appropriately? How do we credit it? What is acceptable versus unethical? And how do we help clear up the gray area? Because I think right now, as this technology is evolving so quickly, there's a lot of gray area where even the other day I was giving a talk and I had used AI to help me, kind of come up with some ideas for ways that I could make it more interactive. And I found myself saying, wow, well, how do I credit Gemini or ChatGPT for their assistance in this talk or in this activity that I'm going to be leading? Because I feel like I should, but I don't have a lot of guidance to tell me how to do that or when it's necessary. And so there are lots of publications that are coming out around this as it relates to medical education and more broadly. I think it's keeping up with those so that we can understand when and how we need to be, making sure to maintain these boundaries. Bias and fairness, as Dr. Rydell spoke about, especially when it comes to admission selection. So thankfully, we have, I think I'm assuming in Canada, some of this is similar, but these bodies of educators and academic leaders in this space are coming up with some guidance for how to use generative AI in this context. What do we do about misinformation and hallucination? For any of you who have experience with generative AI, it loves to hallucinate. It probably will for a long time. And that's something that we have to become facile with. And I think it comes down to both utilizing them so you can appreciate and learn to tell the difference, but then also, again, kind of resting and reminding people who are, especially our learners who are starting to experiment with how and when to use AI, reminding them that AI is not a replacement for humans. It is here and meant to augment, and that we have to stay in the loop to maintain a high enough standard for us to use it with any level of confidence. And then last but not least, again, kind of speaking to that point of content ownership, copyright, licensing. So who owns the output of a generative AI, response to your prompt that you've put in? Do you own it because you prompted it? Does the generative AI model that you use, the LLM that you use, did they have ownership to it? Who owns that? There's a lot of conversation going on in that space. So let's say you come up with a standardized patient example utilizing, ChatGPT. How do you, or can you license that case? And what does that look like? So Creative Commons is starting to develop some content in this area, as well as different, I know Stanford, as it comes to intellectual property, is working through what to do in these cases as well. So thank you so much. That's the end of our content. I'm gonna take down my screen so that we have an opportunity to have some discussion, but this is also a QR code to our website, which we're happy to share later. So thank you all for your attention, and I appreciate there are some questions in the chat, but would also welcome you to unmute yourself, raise your hand.
Thank you very much to all of our speakers for those thoughtful and insightful and thought-provoking talks. So I think we are now good to open the floor for the questions. So you can either write your question in the chat box or raise your virtual hand to ask your questions. I see Marianne raised her hand. So Marianne and then Roland.
Hi, thank you so much for this presentation. I'm Marian Dove. I'm a family physician and I'm the chair of the Department of Family Medicine. So I just wanted to say I really appreciated the whole overview that you gave. And I think it's just kind of increasing exponentially now, the use of AI. So this morning I was in clinic and I had my first patient come in with a major depressive episode who said she had used ChatGPT as her therapist. And she was telling me that she was actually touched because ChatGPT told her to go see her family doctor. And then also said, I'll be there for you after the appointment. And so she was very happy that ChatGPT was still going to be there. I mean, it's just incredible what it's doing actually and how much our patients are using it. On the medical education side, we actually have a group in the department that is working on developing a tool that will generate what we call field notes, which are sheets of feedback for a learner after a half day of clinic. And so this is a super exciting innovation that we are working on and that we're probably going to be presenting at some point to the department in the near future.
That's really exciting. Yeah. I think your point about that, I'm passionate about mental health as well as it relates to AI. And I think it's also a really good example of, I think it brings up this fact of we're all using AI, or variably maybe, but our patients are, and they're finding it. So your patients using ChatGPT, which has no training when it comes to mental health care, right? And there are actually, the FDA just approved a AI therapy bot, or for us, the FDA just approved an AI therapy bot that actually is trained to not give patients, because we give patients poor advice, right? And so that's a great example of how can we help, what is our role as primary care doctors and family physicians to direct our patients to some of these tools that may be safer for them. Because that patient sounds like has had a good experience, but we've also read in the news and know that these bots can go down really dark holes. And so that can be really dangerous. And so how do we help protect our patients in that way as well? Yeah, it's complicated for sure. Roland, I saw your hand up next.
Thank you. So I'm a practicing family doctor working here in the Department of Family Medicine. I think my question is for Dr. Rydell, who talked about simulation as a strategy for feedback. And the reason why I'm talking is because I am tasked with teaching family medicine residents at McGill about the skills of shared decision making. So we get together like 1/2 day a year. There's a lecture and a workshop, and it's a one-off kind of thing. And then they go back to their lives as residents. And there's no structured practice and feedback around their communication skills for shared decision making, to my knowledge. It happens, I'm sure, but it's a bit hit or miss. So I was wondering, how do you use simulation, or is AI even needed in that context? If you want to give a structure to residents to learn communication skills after a one-off educational session, could you speak to that a little bit?
Yeah, I would say that at least from what I have heard from other institutions and just word out on the street, we're still in the early phases when it comes to AI and simulation, in that many institutions have great ideas and then realize that if they want to focus on a particular skill or a particular area in which they want to give feedback, they are going to have to do some of the training themselves. And so it's a start, but I would say that just because the AI tool is there, you don't necessarily have to use it. If you have, for example, the staffing, or you find that the person-to-person feedback is more effective, right? So you're saying, do I even need to use this tool if I want to give feedback about communication skills? And it's interesting, Dr. Bajra and I, a couple years ago, were exploring with a startup, how we could possibly incorporate an AI tool to give feedback to our own students within the family medicine clerkship. And this was a startup that focused predominantly in the clinical realm. Rika, let me know if I get any part of it wrong, but it's mostly for like nurses who are doing callbacks in the clinic, and the AI tool was meant to like kind of go through the checkbox of, did you confirm the patient's name and state that they're in, and all the different things that they have to do as part of their script. And what we realized is that at least a third to maybe a half of what we were looking to assess for communication were nonverbals, nuance, tone. And so we kind of hit a wall, at least this was 2 years ago, as to what this AI tool could help us with in terms of grading. Now, of course, 2 years later, we are probably going to re-explore with different companies. But again, a lot of times around these simulations, if it's not just specifically procedural or specifically, like rote content, we have to think about the human side of things too, and what the limitations are. Because from our nonverbal standpoint, there were, facial expressions and things like that we wanted to have the tool recognize, and it did not have its capacity. So I don't know if I'm answering your question, but maybe Dr. Bajra.
Yeah. No, I am. I was thinking of the same example. When Roland, you brought it up, essentially what we ended up thinking about was using the AI tool for the non-nuanced communication, like the facts of the data. Like, for example, in your case, it might be the clinical reasoning, just more medical facts. And then the communication part was the part that we focused on more. So I could see that in the future, if we use an AI simulation tool, it might be like, did they introduce themselves? If it was a gender affirming case, did they ask for pronouns? But we would do the more subtle, communication skills, verbal, nonverbal, in terms of partnering statements and warmth and empathy and things like that. So I think it can offload the observer to focus on the parts that are very human, and in that way, it can be helpful. But I would agree that it might be a little ways off before it can be completely used for, communication in a more nuanced manner. So that's how I see it as well.
Well, thank you. That's a great answer. Thank you. Lots to think about.
And Roland, I put it in the chat, but there's a MD PhD who's working at Stanford right now, who's partnering to develop Clinical Mind AI, which is an open source tool as it relates to simulation. I put the link in the chat. So I would encourage you to check that out too. It's still beta under construction, but there's a lot of content there actually that's usable right now. And it's free, which is great.
Thank you.
Right. Thank you very much. So I think Charo.
Yes. So first of all, thank you very much. I have loved any of the slides that you have used. Excellent presentation. My question is related to the appropriate use of all these tools, either for research, in teaching, or in clinics. And you have discussed about the appropriate use regarding confidentiality, ethical use. But what about the responsible use at the environmental level? And I'm telling you that because I knew that just recently, and I was working and listening to the radio, and it was a segment that they were the journalists specialized in technology said, don't be kind with this type of tools, because if you say good morning, how are you, thank you very much, these kind of things consumes a lot of energy and a lot of water. You cannot use that because, as Mario has said, it has brought to my mind, this dialogue that you can establish with the AI can be, it seems that they are humans because they show this kind of go to your family doc and then I will be here for you. For people who are very isolated, they feel depressed. So this another issue, is the therapeutic effect of using this type of things. But my question to you is regarding environmental issues, because the consumption of water and energy is huge. Huge. So do you have anything to add?
Yeah, absolutely. Thank you for asking that question, Charo. So we actually have one of the members on our research team is incredibly passionate about this topic. It's something that's being under talked about, and it's something that we actually also recently. Your example is so coincidental. That question came up in a workshop that we recently ran, and one of our colleagues from Google was there who works on building LLMs. And he had an interesting perspective. His thought was, actually, we do show better model performance when you're nicer to LLMs. So you want to have the niceties, and ultimately the value add is probably there because the thank you or the personalization is such. So AI, it works in tokens, right? Every word is a token. So the 2 words to say thank you, actually relative to your prompt, is quite small. And so the environmental impact of being polite to a chatbot is actually relatively small and actually yields a benefit. The politeness yields a benefit in the responses that you're going to have and the interaction with the AI. So his perspective, which I thought was really interesting, was actually to balance it, right? So don't be overly
rude
with your AI chatbot, but it's good to be nice. Like, you also don't want to be terse, because then you're probably not going to get the responses that you want. And ultimately, the small words that you put in are relatively so small compared to your overall everything, the tokens that you're requiring for your conversation. So that was an interesting perspective that I'll share. But then the other is, so the environmental impact. So the question is really big and very important, and I think it really comes down to responsible use on big, broad system levels, right? So one of the things that came up, so Stanford right now, this draft message tool. So we're generating a draft message response for every patient message that comes in that which is for the vast majority of patient messages that come in, there's a draft response generated. And only about 20% of them are utilized, right? So now that they've been watching the data. And so one of the things that we've been talking about in our team as people who've been participating in the evaluation of the implementation of this tool is, how do we bring that environmental impact to the table when it comes to, all right, we've been looking at it, we've watched it, we know that only 20% of these are being utilized. Should we think about implementing this in a different way that could be more environmentally conscious? Because it does have a cost, not only the energy cost in terms of a financial cost, but the environmental impact that it has to utilize these tools, I think, is a really important part. And so our team, the way that we're thinking about it is to ask those questions, because it's hard for us on an individual level you can use AI thoughtfully, right? So don't use it for everything. You can be, judicious in your own utilization of it as it relates to just understanding the environmental impacts that it has for every question that we ask and every way that we use it. But then also encouraging the people who are making the bigger decisions to think about it too. And so I don't have any answers, but that's what we're doing, I guess I should say. And we are thinking about it a lot.
That makes sense, but also if there is this general trend at the international level to be more conscious about the environmental impact of healthcare delivery systems in general, which is huge.
Yeah.
We are incorporating these type of tools for everything, clinics, teaching, research. I agree with you. This questioning about the environmental impact of what we do using this and other things, but we are talking about AI. I think it should be incorporated in the conversation, definitely. So thank you.
They're very exciting areas to do more research on. And actually, recently there was another publication, a report from McKinsey last year that they published. If we are in a stage that are able to implement AI in full scale in our healthcare system, so we can save millions of dollars by just implementing AI fully in our healthcare system. So that's maybe that's the way that we can also compensate from the amount of money that we are investing on or reducing the money that we are investing on healthcare system. So I know we are short in time, but I have one last question that I want to ask. And so I was giving the opportunity for others to ask their questions first as a moderator. So we conducted a study in Montreal from both resident sites and also from educator sites who are doing virtual interviews. And we'll also ask about emerging technologies and use of AI in practice and education, and how much they are motivated, excited to use that or eager to use that in their clinical practice and education. And we saw slightly higher trend of interest in our residents compared to the educators and faculty members on implementing it in education and practice. And I assume this is similar patterns that we are seeing in other studies as well. So I wanted to know if you have any thoughts in terms of how we can build that trust and increase the implementation application of these technologies among already developed family doctors. I know, I've been training residents, also family medicine residents. I see a lot of enthusiasm from residents and medical students, but how we can increase this interest and trust in faculty level and among our family doctors to use it in practice and in their teaching as well.
Dr. Bajra, maybe did you want to talk about the AI Academy? Am I putting you on the spot?
No. Thank you. Thank you for that. Yeah, that's such a great question, Samira. I think that, Dr. Rydell brings it up because it's come up in our institution as well in terms of there's been a push towards developing AI curriculum, but the counter discussion is like, well, you also need faculty to be able to have these conversations with students as it happens in the clinical spaces. And so I think this concurrent idea of faculty development with regards to allowing faculty to be adept and be able to serve as mentors and leaders in this space, I think is equally as important. I think it would be really cool to have an educational tool that, for example, sort of parallels, like the student may be like, it may prompt the student, ask your attending in clinic how she or he uses this tool. And on the faculty development side, it would be a similar exercise. And so we could have these conversations in a structured way. But I do really think that, your question is a wise one, because when I look at my colleagues, I think it's a sampling of faculty who are interested in exploring. And I think that it's really an opportunity for us to have this conversation in a in a matter that is going to shape how it is, how the tools are developed in the future. So from my perspective, I think faculty development, AI Academy is what we're thinking from the perspective of providing foundational knowledge through our primary care division to faculty. And we're hoping to develop some online modules that will allow faculty to engage with the material in like case-based, clinically relevant, and high yield manner, so that they can feel very comfortable in the foundational aspects of AI. So that is our current approach, but I would love to hear from the group if others have thought about it and considered other approaches. Yeah, and very briefly in terms of the environmental, I know that it kind of there is a tension between overusing it and judicial using it, but I do think there's a happens. So I would say that it is important as faculty for us to engage, be curious, and self-educate ourselves with our tool, hopefully with divisional support, like with faculty development, and be ready to discuss it with our learners.
Yes,
Definitely.
thank you very much. Chair, did you have something to say?
No, just thank you again. It has been fantastic. We are really running out of time, and has been. I cannot imagine another better way to close our series of webinars this academic year. It has been fantastic, and really, this is an ongoing conversation that we really think that we will keep maintaining with you. I have been particularly very impressed by the quality of what you do and how you share what you have known so far. And so I really hope that we will keep in touch and doing good things in the future.
Well, thank you so much for having us. Yeah, I really
been
appreciate the opportunity. It's great to talk. I love the discussion. Great
very
conversation.
short, in an hour. We have not a lot of time, but I really think, again, that is the first step in an ongoing conversation with you. Thank you so much.
Thank you.